Welcome back to AIHA Connected, our online patient conference. My name is Erin Anderson, and I'm the Director of Programs and Advancement for the Autoimmune Hepatitis Association. It's my pleasure to introduce our next speaker, Dr. Cara Mack, a pediatric hepatologist from the University of Colorado School of Medicine. She is here today to speak about the new AIH diagnosis and treatment guidelines, which were recently published. She serves as the lead author of these new guidelines, and we're excited to learn more about why they are important and some of the new changes. Welcome, Dr. Mack.
Hi, my name's Cara Mack. I'm a professor of pediatrics at Children's Hospital Colorado, and I'd like to thank Erin Anderson and Dr. Lammert for inviting me to speak on the new autoimmune hepatitis guidelines. How are they created and why do we need them? The objectives of this talk will include going over why we need guidelines, how they're created, and then I'll update you on the new autoimmune hepatitis guideline statements from the American Association for the Study of Liver Disease. And within that document, I'll also update you on guidance statements, which are related to guidelines. Shown here is the new publication from this past year in August of 2020. With the updated guidelines based on the previous ones from 2010. Why do we need guidelines? A guideline is a general rule, principle, or piece of advice. We need guidelines to standardize care in the diagnosis and management of autoimmune hepatitis. Guidelines provide up-to-date management for all providers. Some clinicians may not have access to experts in the field, or they may not be aware of the latest research, and going to the guidelines document provides them with up-to-date management and specific recommendations regarding therapies. Finally, guidelines provide a framework for future research studies. And what I mean by that is if you have the majority of patients who are being treated based on the guidelines, that's a very cohesive group of patients that then you can compare that group of patients treated by the standard guideline recommendations to a new group of patients that might be treated with a new therapy. So it really sets up a framework for research. Another important reason that we need guidelines specific to autoimmune hepatitis is based on the increasing incidence of this disease. Over the past few decades, there's been a nearly 50% increase in the incidence of autoimmune hepatitis, and that's shown in the left-sided graph with the red arrow pointing to the mean increase, showing the steady increase in the past couple decades. In the right-hand graph, it points out two things. Number one, autoimmune hepatitis incidence is much higher in women compared to men. And secondly, there's two peaks of age at the time of diagnosis. One occurs in the teenage years and the second around the age of 60. In 2018, adult and pediatric hepatologists convened to work on updating the AASLD guidelines for autoimmune hepatitis. This process took approximately 18 months to complete, and it was a true honor to work with world-renowned experts in the field, including Al Chaya from Mayo Clinic on the left-hand side and Michael Mons from Germany on the right-hand side. Now, how do we make guidelines? The creation of guidelines starts by generating questions that will answer specific areas of concern. And the format of these questions entails 4 parts, and it's abbreviated PICO. P stands for the patient, and the question needs to clearly define the patient population, such as newly diagnosed autoimmune hepatitis. I stands for intervention, and this pertains to the intervention that's or that's being analyzed, such as the medication prednisone for the newly diagnosed patient. C stands for comparator, where we may want to compare a new drug, such as budesonide, with the standard intervention, such as prednisone. And O stands for outcomes. We need to define what's being measured to accurately compare the intervention to the comparator. So based on the PICO questions that we create, we next go to the medical literature to see what clinical studies have been previously published that may help us answer that specific PICO question. And this process is known as the systematic review of the literature. The systematic reviews were conducted independently by the Mayo Clinic Evidence-Based Practice Center. Once they had completed their systematic reviews, they then presented that to the Guidelines Committee for further analysis and the subsequent generation of the guidelines. Now, the previously published clinical studies are graded based on the type of clinical trial that was performed and the quality of the study. A recommendation or guideline is then created looking not only at the quality of the study, but also measuring other aspects that would impact management, such as the balance of the benefit versus harm, the patient values and preferences, and the cost of the medication. So the three new autoimmune hepatitis guidelines that I'll be going over deal with the three PICO questions as follows. Number 1, what are the most effective therapies for a patient with a new diagnosis of autoimmune hepatitis? And this is also known as first-line therapy. Number 2, what is the best medication to use in the setting of first-line therapy failure or incomplete treatment responses? And this is known as second-line therapy. And finally, should steroids be given long-term, even forever or indefinitely, after liver transplant for autoimmune hepatitis? So here is the complete systematic review data for all three PICO questions. The initial search of the database identified over 1,700 studies, and that's shown in the top highlighted box. Of these, 578 full-text articles were assessed for eligibility, and the vast majority were excluded due to multiple concerns such as study design. So this resulted in only a few studies shown in the bottom boxes for final guideline determinations. First, what is the best first-line therapy for newly diagnosed autoimmune hepatitis? The patient population are those with newly diagnosed autoimmune hepatitis. The intervention is comparing prednisone alone or in combination with azathioprine, and azathioprine is also known as Imuran, comparing that with the comparator budesonide in combination with azathioprine. And the outcomes that we measured included being able to achieve remission based on normal liver tests, the time to remission, medication side effects, and the risk of liver transplant. So shown here are the results from the analysis of the previous clinical studies, and I'll walk you through this diagram, which is known as a forest plot. On the left are the names of the authors of the clinical studies that were analyzed. The results are shown in the middle, with the average of both studies shown with the diamond. Now, if there's no difference between groups, the prednisone group versus the budesonide group, then that diamond would fall right in the middle on the blue line. However, in this analysis, the diamond was shifted to the right, favoring the budesonide with azathioprine group over the prednisone with azathioprine group, suggesting that in these two studies, budesonide was more effective than prednisone. Based on the systematic reviews and our expert opinions, the final guideline recommendation is that for children and adults who present with autoimmune hepatitis, the AASLD suggests that either budesonide with azathioprine or prednisone with azathioprine can be used as first-line treatment. The reason that we did not recommend budesonide over prednisone is due to the fact that these recommendations were based on only 2 studies. Secondly, for children and adults who present with cirrhosis or very severe autoimmune hepatitis, we recommend that budesonide not be used. And this is because in the setting of cirrhosis, there's decreased availability of the drug, and in the setting of severe autoimmune hepatitis, budesonide has not been studied at all. Now, shown here is an example of the detailed information that is provided in the guidelines document. And I show this chart to give you an example of the incredible detail that the clinician receives when they open up our guidelines document, and it provides a very complete plan on the initial treatment and management of the newly diagnosed patient. Moving on to the second question, what is the best medication to use if first-line therapy doesn't work? And this is known as second-line therapy. The patient groups here are those with newly diagnosed autoimmune hepatitis that were treated with the first-line therapy, steroid or budesonide, who either worsened, and that's known as treatment failure. They failed to achieve remission, and that's known as an incomplete response, or they couldn't tolerate the azathioprine, and that's known as drug intolerance. So in those patient groups, our intervention was mycophenolate mofetil, abbreviated MMF, also known as Cellcept, and our comparator was tacrolimus, abbreviated TAC. The outcomes that we looked at were differences between the 2 medications with respect to achieving remission, frequency of medication side effects, and the risk of needing a subsequent liver transplant. Here are the results, similar to the last forest plot that I showed you. However, in this setting, the diamond within that forest plot crosses the blue line in the middle, telling us that there was no difference in outcomes between MMF and tacrolimus for second-line therapy. Therefore, in children and adults with autoimmune hepatitis who have treatment failure, incomplete response, or drug intolerance to the first-line agents, the ASLD suggests the use of either MMF or tacrolimus to achieve and maintain remission. Now, based on the superior ease of use and safer side effect profile of MMF, the ASLD suggests first trialing or treating with MMF as the initial second-line agent in patients with autoimmune hepatitis. And if you don't get a response to MMF, then consider the use of tacrolimus. Moving on to the final guidelines that pertains to liver transplantation in autoimmune hepatitis. We know in autoimmune hepatitis that it is the indication for up to 5% of all liver transplants in both adults and children. We also know that recurrence of autoimmune hepatitis in that transplanted liver, 5 years after transplant, the recurrence of disease ranges from approximately 20 to 30% in children and 30 to 60% in adults. And for many years, even decades, many clinicians have used steroids long-term or indefinitely after transplant to try and prevent recurrence of autoimmune hepatitis. And this chronic use of steroids, usually prednisone, has been debated in the past many years. So, to answer the question, does long-term use of steroids really change the outcome after liver transplant? Our PICO question was generated. Our patient population are adults and children who are liver transplant recipients for autoimmune hepatitis. Our intervention included the indefinite use of steroids in the maintenance therapy post-transplant, and our comparator was withdrawal of steroids in a brief period of time, usually 6 months to a year after transplant. The outcomes that we measured were related to transplant: the frequency of recurrence of autoimmune hepatitis, the number of episodes of rejection, the risk of retransplant, and the frequency of other adverse side effects. The results in comparing the use of steroids versus steroid withdrawal after liver transplant revealed no difference between groups. Again, you can see that the diamond crosses the midline and crosses that blue line, and therefore there was no significant difference in outcomes after liver transplant, whether or not steroids were given long term. So based on the limited data to support long-term administration of steroids to prevent post-transplant rejection or recurrent autoimmune hepatitis, the AASLD suggests that a gradual withdrawal of steroids be considered after liver transplant. Now, for this final section, I want to talk about numerous guidance statements that our committee generated based on a consensus statement that was developed after formal review of any literature that was out there on a specific topic, as well as our group's expert opinion. And the reason these are guidance statements and not guidelines is because there weren't enough studies, quality studies, to warrant a systematic review, and therefore we could not create a guideline. So here are the list of consensus statements that were developed by the panel, and many of them include areas involved in the diagnosis and long-term management of patients. There won't be time to go over all of these different guidance statements, and I'm going to be discussing the ones shown in bold. This is a flow diagram that's in the document regarding the evaluation of a patient who may have autoimmune hepatitis. And I don't plan on going over this in any kind of detail, but I wanted to show you this as another example of the complete picture and flow that we provide for the clinician so that they can accurately diagnose autoimmune hepatitis. At the time of diagnosis of autoimmune hepatitis, other liver diseases can occur, including fatty liver disease, and this would most commonly be seen in the patient who is overweight or obese. In one study, liver biopsy findings of fatty liver disease were present in up to 30% of autoimmune hepatitis patients. And shown here is a picture of a liver biopsy tissue, and all the white circles are excess fat that is stuck in that liver. And this is important to know because if you have fatty liver disease at the time of autoimmune hepatitis diagnosis, it may influence your first-line therapy. For example, we may choose Budesonide if possible because it has less side effects such as excessive weight gain compared to Prednisone. A recent single-center study of 73 patients with autoimmune hepatitis found that 16% of them also had fatty liver disease, and those that had fatty liver disease had a significant increased risk of liver-related mortality and other adverse or poor outcomes. Now, people with autoimmune disease, such as autoimmune hepatitis, are at risk for having a second autoimmune disease, such as those shown in the picture on the right. In autoimmune hepatitis, anywhere from 14 to 44% of patients may have another autoimmune disease, such as the ones listed here. The most common concurrent immune disease with autoimmune hepatitis is autoimmune thyroid disease, and this occurs in anywhere from 10 to 18% of patients. Celiac disease frequency is also significantly greater in autoimmune hepatitis compared to the general population, and approximately 3% of autoimmune hepatitis patients will have celiac disease or develop celiac disease. So based on these findings, a guidance statement from our group was that all newly diagnosed patients with autoimmune hepatitis should be screened for celiac disease and thyroid disease because those are the two most common concurrent autoimmune diseases. In addition, at any time in that patient's care, if there is suspicion based on symptoms or other concerns for other autoimmune diseases such as rheumatoid arthritis, inflammatory bowel disease, or diabetes, you should screen for those diseases at that time. In addition to the fatty liver disease, there are two other liver diseases that are more common or can be seen, I should say, in the setting of autoimmune hepatitis. And if you have these diseases with autoimmune hepatitis, it's known as overlap syndromes. The first overlap syndrome is autoimmune hepatitis and primary biliary cholangitis, and this occurs in adults, and a picture of the bile duct injury is shown on the right there. Now, in this overlap syndrome, these patients have more evidence of delayed bile flow based on symptoms such as itching, higher alkaline phosphatase, and GGT. These patients usually have an anti-mitochondrial antibody that is positive, and then to prove that you have overlap with PBC, you'll want to get the liver biopsy as shown on the right. The other overlap syndrome is autoimmune hepatitis with primary sclerosing cholangitis. Similar to PBC, PSC often presents with itching, much higher alkaline phosphatase and GGT. In this overlap syndrome, there is a very high incidence, almost up to 70-80% of associated inflammatory bowel disease in those patients. And to diagnose the PSC component, a special MRI study known as an MRCP is warranted, and it shows the large bile duct injury shown on the right there with the yellow arrows pointing to multiple areas of narrowing or stricturing based on the scarring. So because of these known liver disease overlaps, another guidance statement suggests that you look for these diseases based on the characteristic findings that I've just detailed. Now, what about prior to treatment evaluations? One area that we addressed in detail in the document are guidance statements pertaining to bone health. First, a bone mineral densitometry or DEXA scan should be performed at diagnosis in all adults with autoimmune hepatitis who have risk factors for osteoporosis or thinning of the bone. And the DEXA scan should be repeated every 2 to 3 years if that patient remains on long-term use of steroids. Second, blood levels of vitamin D should be assessed at the time of diagnosis and every year thereafter. And supplementing with calcium and vitamin D should be provided while on steroid therapy, whether it's Prednisone or Budesonide, and should be continued or restarted at any point that you identify deficiencies in vitamin D. Now, switching gears to how to monitor the liver disease during remission. Many of you are familiar with FibroScan. This ultrasound-like device measures stiffness of the liver that reflects the amount of scarring or fibrosis of the liver. FibroScan generates a number as shown on the right, and that number reflects the severity of the scarring. The higher the number, the more scar tissue in the liver. So based on this new tool that we've had for a few years now, an additional guidance statement is to monitor for liver scarring on an annual basis with the FibroScan. One word of caution with FibroScan. FibroScan should not be performed in the first 6 months where a patient is newly diagnosed with autoimmune hepatitis, and that's because the inflammation in that liver associated with the autoimmune hepatitis can also elevate your fibrosis score. So you want to treat the patient, get them in remission within 6 months, and then a few months later, and definitely by 12 months, check your first FibroScan to get a baseline read. Finally, when do we consider stopping therapy for autoimmune hepatitis? And this is known as treatment or drug withdrawal. Drug withdrawal and long-term treatment-free remission of autoimmune hepatitis should be considered in patients who have normal liver numbers, AST and ALT, as well as a normal total IgG level for at least 2 years while on therapy. A liver biopsy prior to drug withdrawal is valuable and recommended in the majority of cases to ensure that there is no active autoimmune hepatitis within that liver. You can actually have normal liver tests and still have some inflammation inside that liver. So a liver biopsy is really helpful to ensure that the disease is in complete histologic remission, is what we call it when we look at the liver biopsy remission. And it will also help predict relapse of autoimmune hepatitis based on the findings. Recently, it's been suggested that liver biopsy is not mandatory in adults. However, in children, it is still recommended that a liver biopsy be performed prior to considering removal of treatment therapy. Next, if you're going to take someone off their azathioprine, for example, they must be closely monitored for recurrence of autoimmune hepatitis with very frequent labs in that first year after drug withdrawal and annually thereafter. And if they have recurrence of autoimmune hepatitis based on rising liver tests, you're going to need to reinstitute the medications to again induce and maintain remission. So in summary, budesonide or prednisone with azathioprine are recommended as first-line treatments for autoimmune hepatitis in children and adults. Mycophenolate mofetil or tacrolimus can be used as second-line treatments in children and adults with autoimmune hepatitis who fail to respond to the first-line therapies. Prednisone can be discontinued after liver transplant and patients monitored for recurrence of autoimmune hepatitis. And finally, the Autoimmune Hepatitis Guidelines document also contains multiple guidance statements on all aspects of the workup and management of autoimmune hepatitis. So where do we go from here? The creation of the guidelines showed us that there are many unmet needs in autoimmune hepatitis that warrant future research. First, we need more large, appropriately powered or numbered, multi-centered comparative effectiveness treatment trials where we are able to compare one drug against another and determine, based on having a big enough group in those trials, determine if one drug is superior to the other. We need to identify prognostic biomarkers in the blood that would predict the risk of treatment failure, relapse after drug withdrawal, or progression to cirrhosis. We need research on therapeutic therapeutic biomarkers within the blood that would reflect remission if we were to biopsy that patient. And therefore, if we can identify therapeutic biomarkers, it may one day negate the need for needing the liver biopsy prior to drug withdrawal. And finally, we need to continue research on therapeutic agents that can restore a normal immune system that prevents autoimmunity. Thank you.